that the chance of a permanent colostomy is less if you do preoperative radiotherapy. Again, this is not randomized, so this is a flawed conclusion, but the numbers are pretty convincing. In the German trial, the surgeons were asked when they first examined, will this patient need an abdominal peritoneal resection? Will they need a permanent colostomy or not? And then they're randomized. And the patients in whom the surgeon said they will need an APR in the left column, preoperative radiotherapy, 39% of those patients had sphincter preservation. On the other hand, the post-op patients, only 19% had sphincter preservation, highly significant at a p-value of 0.004. So again, these are not randomized data, but they're pretty convincing that the chance for avoiding the dreaded colostomy increases if you give preoperative radiotherapy. So preoperative radiotherapy is superior. It decreases local failure rate, much less acute and chronic toxicity. Patients tolerate it better, and probably increases the chance for avoiding a colostomy. The downside is not, of preoperative radiotherapy is not insignificant. In the Dutch trial, again, I won't go over these data for the sake of time, but how do you know if a patient needs radiotherapy? They need radiotherapy if they have positive nodes, or if their tumor goes all the way through the rectum, so-called T3 tumor. How do you figure that out? Well, it's hard. CT scan is worthless. State of care in the United States is an ultrasound. Ultrasound overstaged 18% of patients in the Dutch trial. In other words, they were, based on their ultrasound, they were felt to be T3. Final pathology came back T2N0. So they could receive radiotherapy. They didn't need it. And that's the bummer with giving everybody radiotherapy. I think there's a trend in the